Hello, this is Mrs. White, and this video we will be focusing on a part of the kidney that is so super important, the glomeruli and basically the nephrons. So I've labeled this, oh my glomeruli. I thought it was a little cutesy. But if you know me, you know my favorite organs in the entire world are the kidneys. And one would think that I would love to talk about disorders of the kidneys, but it's like talking about a sick child. It doesn't spark joy in me. But alas, we must learn this stuff because as nurses, we can do a lot of positive things that can help get those kidneys back functional and assist our patient through these terrible, terrible times. As always, we are going to use NextGen as we pick these things apart, including the clinical judgment model of recognizing and analyzing cues, which are assessing the patient, reviewing the chart, considering the patient and their values, taking relevant from irrelevant information, being able to parse that down, looking at past medical history and certain characteristics of your patient that may be important, so those things which would lead into risk factors. Analysis is more clinical. Are there patterns? Do we need more data? And from there, we prioritize hypothesis, which is these most pressing concerns, the possibilities, the priorities, risks related to the disorder, risks related to the solution, and making sure we're going after those which are the most important and generating solutions and take actions. This is planning, implementation, and evaluation back in the old nursing process. These are patient goals, their expected outcomes, their plan that we've implemented, including the skills, procedures, collaboration, teaching, ethical concerns, and then how do we know that the patient is doing well? How do we know when to call the doctor? And then, of course, I have a little spot for medications to know. All right, so we're going to get popping into here now with glomerulonephritis. So glomerulonephritis, if we were to just break the word apart, basically means inflammation of the glomeruli. There can be a couple different ways that the glomeruli have disorders. One would be primary, which it starts in the glomeruli itself, or secondary, which is due to a systemic disease. So two different causes. And then on top of that, then a couple different types, whether it would be acute or chronic. So acute is sudden and reversible versus chronic, which is slow and irreversible. We spend a lot of our time talking today about acute primary, including post-streptococcal glomerulonephritis, because that's one of the most common ones that we see as nurses. So some of the ways that we could have acute primary would be group A strep, strep pneumonia, Klebsiella. Acute secondary would be due to disorders like lupus, liver cirrhosis, diabetes, Goodpasture disease, which Goodpasture is an autoimmune and very rare, but we have to talk about it just in case you see it come up. And then basically the chronic often we don't know the exact cause, but we have definite risk factors. Hypertension, infections, things that cause decreased renal perfusion, diabetes. So when we find chronic glomerulonephritis, it's usually found incidentally, which is why it's so important that we get our urinalysis done every year. This is why when you go to the doctor after a certain age, they check your UA. So for our patients, it's very important that we do that, because they may not have a lot of signs and symptoms like somebody who's acutely ill, but they could be careening towards the need for dialysis, and we have the opportunity to slow that down if possible. All right, so going back to more of the acute glomerulonephritis, some of the associated conditions with this would be things like urinary tract infections, nephrotoxins, some immune disorders, systemic diseases, which we talked about as the difference between primary and secondary. But the most common that you're going to see and what we're going to spend time talking about and what this picture really shows is post-streptococcal glomerulonephritis. And that is a mouthful. So post-strep glomerulonephritis. Common among the kids because they tend to get strep infections, and then common once we reach into our 60s. Basically, it happens 1 to 2 weeks after strep infection. When we think of strep, we often think of sore throats and upper respiratory, but strep can also invade the skin, so things like impetigo. So look for those clues in the patient history. And what are the signs and symptoms? Well, you know what? Before I go into the signs and symptoms, I want you just to look at the patho a little bit. Basically, the inflammation of the glomeruli is due to an excessive immune response, which damages the basement membrane. So the antigen-antibody complex damages the basement membrane. Increased inflammation from that antigen-antibody complex decreases the GFR, can lead to acute kidney injury, which leads to kidney atrophy and decreased number of nephrons. So this can actually lead to nephrotic syndrome, which we talk about in this presentation, and can lead to end-stage renal disease. Now, the good news is that 95% of people with acute glomerulonephritis will recover, but 5% don't or go into chronic glomerulonephritis. So what do we see? What does the patient look like? We may have some general signs and symptoms of lethargy, pallor, headaches, irritability, abdominal and flank pain. But the one thing that we are looking for, we'll see a lot, is this periorbital edema. That's how it starts. It's one of the first problems that we have as we're having some trouble with our fluids, right? So we're starting to retain fluid. We're letting protein and other particles that normally wouldn't be filtered away, they come out in the urine. So it starts at periorbital edema, but this can progress to ascites. It can progress to pulmonary edema. It can progress to anasarca, which is generalized edema. The person may have hypertension, fluid retention. The urine that they do have is often described as being smoky or cola colored. I almost said cola flavored, but it is not cola flavored, only cola colored. The hypertension with this tends to be mild to moderate. And sorry, I'm just looking over my notes here. Basically, that's about it, right? The urine, and this becomes diagnostic. The urine, we are losing protein and blood in the urine, because remember, nephron as a functional unit filters waste and water from the blood, and it filters small particles, never blood and never protein. If we're seeing blood and protein, there's a problem. So some of the relevant diagnostics that we would expect to see for our patients, and remember, you're responsible to know the patient teaching on these and how to prepare a patient and how to recover a patient. So the urinalysis, which would show erythrocytes and casts, which are formed particles, protein. If we did their labs, it would show increased BUN and creatinine, which is called uremia, and a decreased GFR. We look for, in their diagnostics, we look in their history and physical and look for those risk factors and recent events. Renal biopsy can confirm what's going on in the kidneys. We can check a 24-hour urine, and that will help us quantify the protein excretion to see how much protein the person's actually losing. As far as other labs, now this is very special labs that will help us to differentiate if the person has post-streptococcal glomerulonephritis, which is the anti-streptolysin O, or an ASO titer. And then we also can look for decreased complement components. And for this, the person's serum albumin would generally be decreased because they're spilling their protein in the urine. So knowing that that's what the patient presents as, that their blood pressure is elevating, that they're spilling their protein, what are some problems, right? What are our priorities that you think can happen? Well, we could have a problem with perfusion with the increased blood pressure. We could have a fluid and electrolyte balance problem because of the fluid volume excess, in addition to the renal dysfunction. As we are going into acute kidney injury, we can have problems with our potassium. So what would you think would be good goals or solutions? What do we want? We want a normal fluid and electrolyte balance. We want to decrease the patient's edema. We want to make sure their vital signs are within their baseline. And we want their intake to equal their output, right? So we want to basically monitor and restore kidney function and prevent complications due to reduced kidney function. All right, so let's go over to some of our interventions and see if we can figure out what would be good things to do. All right, so some of it is dietary, right? We need a dietitian on board, but we need to look at their diet, and often we're restricting sodium. We may be restricting fluids and restricting their protein. However, the protein's a little wobbly because if a person loses a lot of their protein, they may require some additional protein, so we need to be able to monitor it. But understand that too much protein in our kidneys that are already having trouble is actually a bad thing. We need to treat the underlying cause, so antibiotics if it's strep. So, and then the teaching that goes right along with somebody on antibiotics of taking all the antibiotics as prescribed, looking for secondary infection. If the problem that we're treating is not post-strep, but instead an autoimmune disorder, let's look at good pasture syndrome, which is autoimmune. We would treat it with steroids, immunosuppressants like rituximab might be something that we would treat with. Plasmapheresis to decrease the amount of immunoglobulins that are in the blood that are, the immune antibodies. Okay, so just going back to generalized care, often the patient needs rest until they stop losing the blood and protein in their urine. Vitals every 4 hours at the very least. Checking their lung sounds, because remember, the danger is that the fluid accumulation can affect the respiratory system, and that's an A priority, right? A for airway. Daily weights, checking abdominal girth. Notifying the doctor if we have signs of increased fluid retention, including JVD, increase in their weight, shortness of breath. Think about edema and how edematous skin looks and what that might do to the patient, and what are some things we can do for the patient with edema. That looks like turning and positioning, good skin care, good infection control because of the impaired skin integrity. We need to treat fluid overload. And how could we treat fluid overload? Hopefully you're saying diuretics, Mrs. White. Diuretics, yes, absolutely. Treat their hypertension. So how do we treat hypertension? I hope you're thinking antihypertensive medications. And we need to treat increased potassium and uremia. And if it gets to the point that the person is uremic, they may actually require dialysis or renal replacement. Now that's a difference. So that's a management of the acute glomerulonephritis. Now, what about management of chronic glomerulonephritis? For that, it's slow down and prevent complications. Treat those disorders which lead to chronic glomerulonephritis, hypertension, diabetes, any known agents. Understanding that if we don't get this slowed down, then eventually the patient will need dialysis. And that's a fairly common thing with glomerulonephritis, unfortunately, for chronic sometimes we don't even find the patients until they're almost dialysis ready. So go ahead and put your notes down, go back and do your reading, and see if you agree with my assessment on glomerulonephritis, especially post-streptococcal. Now, the next thing we're going to talk about here is nephrotic syndrome. Let me pull that up here. So nephrotic syndrome, again, let's go back to the beginning. This could be a complication of glomerulonephritis, but nephrotic syndrome is when the glomerulus becomes permeable to plasma proteins, causing massive proteinuria, edema, and low albumin. Remember, the nephron's the functional unit of the kidney. So this one's a little bit, in my opinion, nephrotic syndrome, more severe than glomerulonephritis, because again, glomerulonephritis can lead to nephrotic syndrome. So again, excessive loss of protein, but not just protein, and we'll talk about that a little bit more, but that's the one we think of the most. So the signs and symptoms that a patient is experiencing nephrotic syndrome are large proteinuria. I mean, if you did a 24-hour urine, it'd be more than 3.5 grams of protein in 24 hours, which is huge. Hypertension, hyperlipidemia, and there's a reason for that, because albumin decreases, which increases edema, and this decreased albumin also causes the liver to make more lipids. So as the albumin decreases, the person develops ascites, anasarca. The lipids can be so high that they're spilled over in the urine, and that urine looks foamy. Hypocalcemia, skeletal abnormalities can present from this. Hypercoagulability, as well as, actually, believe it or not, the increased risk of bleeding, but we do focus on hypercoagulability. Blood pressure can be elevated, or it, in the event of severe fluid loss, then it could be decreased. So the causes of nephrotic syndrome are acute glomerulonephritis, and then some secondary causes: diabetes, lupus, Hodgkin's lymphoma, HIV, NSAIDs, penicillin. If nephrotic syndrome happens before the person is 1 year of age, that's a genetic condition. So relevant diagnostics, of course, the urinalysis. It's going to show protein. It's going to show basically loss of a lot of protein. Lipid studies would show increased cholesterol, increased LDL, increased triglycerides. Labs would show decreased albumin, increased creatinine and BUN, decreased GFR. If we did coag studies, it would show an increased PT, increased APTT, increased INR. Some of the other diagnostics, we might need a biopsy to figure out why this is happening. So hypotheses. So what are some things that can happen as a result of this? Of course, the edema and fluid volume excess into the lungs, that could be a problem. Anticoagulant proteins are lost, which increases the risk of clots. So the person's at risk for DVT, PE, CVA, arterial thrombosis. Antibodies are also lost, which can increase the infection risk. And this can definitely lead and progress to end-stage renal disease. So what are the solutions? What do we want? What are our patient goals? We want to cure or control the primary disease, promote renal function, prevent complications, prevent those complications of clotting and stroking out, prevent infection. So let's go back to the diet. Nutrition: low sodium, moderate protein, small frequent meals. You're going to need your dietitian in on this. We may need to fluid restrict them, but also understand if we're fluid restricting somebody, that can lead to dehydration. And people who are fluid restricted, we have to do meticulous oral care. We need to make sure they're comfortable as far as candies and things like that. That's just common nursing care. Daily weights, intake and output, avoiding infection, right? Because remember I said they're losing antibodies in that urine as well, so that puts them at an increased risk of infection. Checking their vital signs, their weights, skin care because of the edema. Looking for those danger signs which could herald something else going on. Signs, let's say, for instance, you have a person with nephrotic syndrome and suddenly they have slurred speech. Could they be experiencing a stroke? They could. What if they experience flank pain? Could they be experiencing like a renal thrombosis? They could. So these patients often need anticoagulation. And as we just talked about in glomerulonephritis, we need to make sure we're taking care of their skin. All right, so medications to know. Nephrotic syndrome, we often will treat with ACE inhibitors and ARBs. So ACEs and ARBs because that reduces protein. It releases the protein in the urine, so proteinuria. Diuretics, especially loop diuretics for edema. Statins to treat the hyperlipidemia, and anticoagulants for DVT clot prevention. In the case of some autoimmune causes of nephrotic syndrome, we might need corticosteroids or cyclophosphamide, and we may need to give albumin to these patients. So albumin is considered a medication. All right, guys, so it's a lot to think about with the glomeruli and nephrotic syndrome, but go ahead and take a look at your notes, do your reading, and thank you very much for your time. Have a great day.